Okay, this lecture is for the start of Module 6. This is Chapter 13, Diabetes. The next section of this module will be Chapter 14, I think. It's the one on other endocrine abnormalities. Diabetes. Well, first of all, before I say anything else, those of you who have taken the exam, quiz 4 or 5 already, grades are looking really good. It's calculating it at the total points that are available rather than a percentage. Of course, none of you are idiots. You can easily calculate your own percentage. Some of you have asked me about the grade book. It's an animal that I don't understand at all, but I assure you there's not a soul who's not passing the class, and hopefully, maybe at least before Thanksgiving, I'll get some assistance and get that lined out so you've got an accurate reflection of your grade. Just know this: number one, everyone's got a passing grade. Number two, I think everybody's got a good passing grade. Okay, so bear with me. We'll get that straightened out. No one's in danger. Okay, diabetes. Diabetes mellitus comes from the Greek and Latin sweet urine. That's how it was once diagnosed once upon a time. I don't recommend that. So the body's got a lot of sugar that it's not regulating for whatever reasons. So we know the pancreas. Sorry, I've got a lot of pancreatitis patients right now, so I'm trying to say pancreatitis. The pancreas is responsible for secretion of insulin, and there may be abnormalities. Type 1 diabetics, these are the people who are insulin dependent. They do not secrete any insulin. You will have diabetic ketoacidosis with a type 1 diabetic. Type 2 diabetics, these are people who are somehow either insulin resistant or there is autoimmune destruction of beta cells, often associated with obesity. These people we can typically manage with oral analogs of anti-diabetics unless we absolutely have to go to insulins, which in these people that's our last resort, but it may happen. Diabetes is also kind of a syndrome more so than a singular disease. It is often associated with hyperlipidemia, obesity, hypertension, things like that. You'll almost always see it in certain other diseases such as cardiovascular disease, peripheral vascular disease, cerebrovascular disease, because diabetes affects your entire body. In fact, one of the physicians who taught me for the first 2 years of my practice, I may have talked about him before on these lectures, Dr. Odibo. He's from Africa, and he always tells patients that diabetes affects you from the very top hair on your head down to the very bottom of your feet, and it's actually very true, it does. Once upon a time, diabetes was a death sentence. We did not know how to manufacture insulin. We were not very good at treating it, and people died because of all the complications of diabetes. So we live in a day today where I get the sense that it's kind of taken a little too lightly. We don't always appreciate just how severe a disease that diabetes is. Don't ever underestimate diabetes. It will kill your patients quicker than anything. And when I say that, you've got to remember all of the things that diabetes can cause that will lead to that, okay? It will kill every organ in your body, and it will make you live long enough while it's killing them that you suffer. So treating diabetes is actually very important. Okay, first thing, hemoglobin A1C. That is basically the new standard for testing for diabetes. It's a 3-4 month record in your own blood of the amount of glucose that's been in your serum. Different ranges mean, it depends on where you are. Some people say that as long as it's below 6%, then you're not diabetic. Some people say 6.5. I'm not an endocrinologist, and I don't have endocrinology consults here, so I manage a lot of diabetes for myself. You have to take the whole patient into consideration here. I have some patients who they've got some hyperglycemia, no proteinuria, Probably very, very, very early diabetes, if it's even diabetes. They may have a hemoglobin A1C of 7 or 7.5. So is my true diagnosis diabetes? For the sake of making sure that they actually get treated, yes. But is this a moment where I'm going to start throwing metformin or glipizide or insulin? No. That's a diet, exercise, lifestyle modification sort of treatment. So don't ever forget that part there. Now, uh, here's a reality situation. Everybody has insurance now, or should have insurance now, and what happens is it's not the ER primary physician abusers that we're worried about. It's actually the people who have chronic diseases like diabetes who are now coming into the hospital. See, you can live with diabetes for a very long time without being treated before it causes you some major problems. So, um, let's say, for example, we have a patient who's had diabetes, who's had no insurance. Now they are able to have insurance through the Affordable Care Act, and they come to the hospital or to your office to begin treatment for this. Well, they're 10 years into their diagnosis, and they've got complications out the wazoo because of it, so it's much more difficult to treat. Um, so the first thing I would say is always get a hemoglobin A1C, okay? Um, Sorry, one of the pharmacists just texted something that showed up on my screen. Okay, so let's break this down, this chapter, into two sections: oral anti-diabetics and insulins. All right, type 1 diabetics, insulin. That's all you need to know. Type 2 diabetics, first line treatment, lifestyle modifications, diet, exercise, okay? At the very most, and some of the things I'm not telling you, some of the things I'm telling you are not necessarily quiz information. It's because I really believe in treating this issue, even though I hate endocrinology diseases. I always encourage my patients to check their glucose no less than 2 times a day, but I want them to do it 4 times a day, just like we do in the hospital. I want to know just what's really going on. And the most important glucose of the day is the one first thing in the morning before they do anything. That's their everyday fasting glucose. That is your baseline of metabolism in the patient's body with regard to glucose. Okay, so diabetes type 2 oral anti-hyperglycemics. This book gives a pretty good rundown. And also, here's some quizzable information. On page 224 at the bottom right-hand corner, these are recommendations from the American Diabetes Association for steps to treat diabetes. Look over those. That'll probably be on the quiz. Okay, first group, the oldest group, sulfonylureas. These are very good at lowering glucose. For example, well, let's not say for example, but the book talks about first and second generations. We're only concerned about second generation here. I don't even think anybody manufactures first generations anymore. So second generation is going to be glyburide, glipizide, glimepiride. I mainly do glipizide myself, and I'll talk a little bit more about them here in just a second. So these are called secretagogues. They coax the pancreas into secreting insulin. So they're often a first-line treatment. And they're very good at this. They make the pancreas do what it's supposed to do, so this is actually probably the most natural means of reducing glucose in the blood. Now, the main side effect also is hypoglycemia. They work very well and people can become hypoglycemic. Now, I was talking about glipizide and glyburide. Glipizide does a good job, and it doesn't linger in the body as long as glyburide does. And here's something. If you have a patient who's hypoglycemic, they're diabetic and now they're hypoglycemic, they're hypoglycemic for days, and you stop their glyburide, they're going to be hypoglycemic for days. It takes several days for the medication to be metabolized out of the human body before the glucose will start to trend back up. So be very careful with that. And I guess what I'm getting at, I don't prescribe those to elderly people at all. At all. they will die from hypoglycemia with a sulfonylurea. There may be case-by-case scenarios, but I don't see too many elderly people with glucose of 500 because most of them aren't eating enough anyways, even if they are diabetic. So that aside, they are very good medications. I personally like glipizide. Main thing is, what do? They make the pancreas secrete insulin. It's an oral medication. You can prescribe it once a day. You can prescribe it twice a day until it's kind of a